Here, we're going to be walking through this diagram of fetal circulation and focusing on the different directions of blood flow, namely those in utero and those after birth. This image and the concepts here are extremely high yield for test day, so I definitely recommend that you know it. So first off, oxygenated blood comes from the placenta and enters the umbilical vein. This is the location of the highest oxygen saturation within fetal circulation, and it's at approximately 80%. The blood in the umbilical vein has two options on its way to the heart. It can either supply or bypass the liver. Here, 1/3 of the blood will join the portal vein and enter the liver, while the other 2/3 of the blood will bypass hepatic circulation via the ductus venosus, as you can see here. Next, the oxygenated blood, which has bypassed the liver via the ductus venosus, and the deoxygenated blood, which has actually passed through the liver, will rejoin at the IVC, and you can see this here. The inferior vena cava will then dump this blood into the right atrium. And where exactly will this blood go? Well, in this case, there's actually a small piece of tissue within the right atrium that guides the blood from the inferior vena cava through the foramen ovale so that it enters the left atrium. This blood will then go from the left atrium to the left ventricle and be pumped out through the aorta and supply the great vessels, as you can see here. It's important to note that this is where the blood with the highest oxygen saturation goes, through the great vessels to the brain. Now the blood from the superior vena cava will return from the head and upper extremity and go to the right atrium. This blood has a very low oxygen saturation compared to the blood delivered by the inferior vena cava. Since this blood has a low oxygen saturation, we would like it to mix as little as possible with the blood coming from the inferior vena cava. So the blood from the superior vena cava is directed directly into the right ventricle, as you see here. This low oxygen tension blood from the superior vena cava is then pumped from the right ventricle into the pulmonary trunk. Despite this low oxygen saturation, this will still provide enough oxygen for the lungs to develop properly. The rest of this low oxygen tension blood will be shunted to the ductus arteriosus, as you see here. You'll notice that the ductus arteriosus receives most of a low oxygen tension blood from the right ventricle, and its job here is to serve as a shunt that takes place after the branches of the great vessels. This is so the high oxygen tension blood will go to the brain and the low oxygen tension blood can go to the rest of the body. This low oxygen tension blood will then go from the aorta into the iliac arteries and then to the umbilical arteries where they connect back to the placenta. So keeping all that in mind, what happens when a baby is separated from the placenta and it takes its first breath? Well, there are multiple changes that are going to take place hemodynamically. Breathing increases the oxygen tension within the lungs, and this causes vasodilation. Here, it's important to remember that the lungs are the only organ that vasoconstrict in the setting of low oxygen. Also, cutting the cord leads to a huge decrease in circulating prostaglandin E2, which was coming from the placenta. It's important to remember that prostaglandin E1 and E2 both cause smooth muscle relaxation. And it's prostaglandin E2, which comes from the placenta, that significantly decreases after the cord is cut. So without these prostaglandins, what do you think will happen? Well, less smooth muscle is going to relax. So which structures do you think will be involved? Well, that'll be the mother's uterus and the ductus arteriosus. The absence of prostaglandin E2 will cause the uterus to contract upon itself, which will limit postpartum bleeding. It will also cause the ductus arteriosus to contract upon itself, closing off the communication between the pulmonary trunk and the aorta. After the ductus arteriosus has been closed for some time, it will fibrose and form a ligament. And this ligament is called the ligamentum arteriosum, and you can see it here. So if the ductus arteriosus remained open, what medication could you give to help close it? Well, you'd want to give a medication that inhibited cyclooxygenase and prevented the formation of prostaglandin E1 and E2. Can you think of a medication that would do this? There you go, the NSAIDs. The medication that's commonly tested in this situation is indomethacin, which is a type of NSAID, and it's used to close patent ductus arteriosus. Do you know another common situation where indomethacin is used? There you go, in the acute treatment of gout. So from babies to big toes, indomethacin does it all. Alright, now on to a flash quiz. Name 3 important shunts of fetal circulation. There you go. It's the foramen ovale, the ductus arteriosus, and the ductus venosus. And you can see an example of these here. Shunts are quite high yield, because they require you to remember the embryology as well as the hemodynamic changes that take place at birth. Of these shunts, the ductus arteriosus and foramen ovale are particularly high yield. If the foramen ovale remains patent, you can see a paradoxical embolism, which is always a highly tested scenario. And if the ductus arteriosus remains patent, you have a patent ductus arteriosus, which is associated with the rubella virus, causes a machinery-like murmur throughout systole and diastole, is treated with NSAIDs like indomethacin, and can be associated with cyanosis after birth. Let's try a question. A newborn infant is brought to your office for evaluation. On physical exam, the infant appears normal, but on cardiac exam, the baby is found to have a continuous murmur in both systole and diastole. The physician prescribes a drug for the infant, and on follow-up, the murmur has disappeared. What is the mechanism of action of the drug most likely prescribed? Is it A, increases thromboxane A2, B, inhibits prostaglandin E2 formation, C, stimulates M2 receptors, D, stimulates prostaglandin E2 receptors, or F, stimulates prostaglandin F2 alpha receptors? Well, this question is testing a combination of pharm as well as embryology. The child is found to have a continuous murmur throughout systole and diastole, and this is characteristic of a patent ductus arteriosus, or PDA. While we're at it, can you think of a virus that causes a PDA? There you go. Rubella is classically associated with PDA because the virus infects the smooth muscle cells that are crucial for contraction of the ductus. So in this case, the doctor gave a certain drug and the infant's murmur disappeared. Can you think of the drug that closes the patent ductus? There you go, indomethacin. Indomethacin is a non-selective cyclooxygenase inhibitor, so it inhibits both COX-1 and COX-2. This leads to decreased amounts of all the prostaglandins. But the ones we're worried about in this case are prostaglandin E1 and E2. Since prostaglandin E2 is inhibited, this means smooth muscle relaxation decreases. So now the ductus can constrict and close on itself. This will lead to resolution of our patent ductus arteriosus. So after going through all that, can you tell us what our answer is? There you go, it's B. Inhibits the production of prostaglandin E2.